Thanks very much, John. Yeah, I'm delighted to talk about the work of the mental health theme. And in the time I've got, try to do a whistle-stop tour through some of the activities that Lucy and I oversee within the ARC and our great colleagues. But I want to first, well, we're not going to show any videos, but I am going to put in a shameless shout for mental health here, and just to sort of highlight why it matters and why there are concerns. We know that 1 in 6 adults in England suffer from anxiety and depression. So that's data from the Adult Psychiatric Morbidity Survey, reliable data. We also know that across the world, mental health and substance use disorders are leading causes of disability. And very tragically, nearly 1 million people across the globe die each year as a result of suicide. So mental health is everyone's concern, and we need to be having more candid and open discussions about this. But there's another problem which we need to consider, and that is the gap in funding that exists in this area. So years of underinvestment in mental health service delivery and research have meant that actually people with mental health problems can't access services as well as people who have acute medical problems. This is a screenshot from the King's Fund report. This is from 3 years ago now, where they were highlighting that although income for mental health trusts rose by 2.5% in that previous financial year, the comparable figure for acute trusts was 6%. So we have a problem in terms of a funding gap. And that problem is also mirrored when we look at what happens in the research field. And of course, we all strive to deliver evidence-based medicine, and you only get there if you have research and research funding to back that up. And mental health research in the UK is shamelessly and chronically underfunded. So just, under 6% of the UK health research budget is spent on mental health. If you look at the comparable figures for cancer research, it's 4 times higher. An MQ analysis of this, which is now a little old, 2015, but was reflecting back in 2011, that if you looked at spending per head for cancer care, equated to about £1,500 per cancer patient. Whereas we look at comparable figures for an adult suffering from a mental health problem, the figure was less than 10 quid. So we all acknowledge that mental health is a problem, but there's insufficient money here, and the situation is not going to get, I foresee, much better because we've all been struggling with this, which of course has dominated much of today and has completely overtaken all of our concerns. Now, we know that COVID, of course, has caused difficulties with concerns about the risk of infection, the problems that we're all struggling with social isolation. So these has increased the level of risk factors in society for mental health problems. But we've also got this problem, which is a £2 trillion government debt, which is looming somewhere down the road that we're all sort of worrying about. And of course, that's not only going to increase risk for mental health problems, but of course, these problems that I've described around funding are not going to get any better. Be that as it may, the WHO director, Tedros Ghebreyesus, has, thank goodness, has highlighted that it's crystal clear that mental health needs to be a core element of the recovery from the pandemic response. So I say all of that at the beginning because I think it's very important. We can talk about ARCs and various other acronyms, but I mean, the reality is we're dealing with a major public health problem, which we need to tackle. Talking more directly to our theme itself, myself and Lucy co-lead the theme, but there are 26 members of this group. We've got some fantastic public contributors, Naomi, Louise, Anna, and Rosie, who's our PPI lead, who's been fantastic at coordinating effort. And we have representation across the health and social care sector. And we did a little bit better. So this isn't at all competitive than our public health colleagues. We did manage to continue some we did some face-to-face interactions, but actually we've carried on the conversation using Zoom. So we've had several online Zoom meetings where we refined and argued and had cold towels around our head about our various research priorities, which were then ratified independently by the research assessment panel that John leads. And we've come up with some exciting themes, which I'll come to in a moment. But thinking about acronyms and ARCs and ARCs, and I've often, when I first heard about the ARC, I thought, was it an ARC or is it an ARC? Well, of course, we all know what an ARC is, an ARK. It's the thing that Noah and his family sailed off into the sea with and saved all of human and animal life during the flood. But actually, in general terms, and on a serious point, an ARC can be thought of as something that affords protection and safety. And these are some of the themes that have very much been in our minds where we've been shaping our priority areas. And they fall into three categories around the fragmentation of care, the mental health of the workforce, and self-harm and suicide. And the southwest of England has some of the highest self-harm and suicide rates. And I'll be trying to talk to you about all three of these, but mainly the first two, because I often end up talking about self-harm. It's a particular area of interest of mine. So turning to fragmentation of care, I mean, what is this? What is this? It sounds rather nebulous. Here we've got, though, the reality. We've got an overstretched GP who's waiting for the next patient. And so all the defenses are up. There's lots of triaging and signposting and all the things that we do to sometimes avoid seeing patients. This is the live reality. These are the words of a woman patient who describes going through a pattern of feeling suicidal, wanting to drown herself inside and having nobody to talk about it at all. If you look at the problem from the other end of the delivery end of the side of things, GPs get hugely exasperated when they try to refer patients into secondary care services or into talking treatments, and they get the patients get rejected. This is a very common and daily occurrence, unfortunately. Partly reflects, well, largely reflects resources, I fear, but also training, possibly. And I'll come to that in a minute. So here we have a GP who's tried to refer a girl because of concerns about her mental health, but the risks are perceived to be too high. The therapists aren't equipped to deal with risky patients, and the GP is stuck wanting to help, but unable to put something into effect. So this is a quote from a study that we undertook with our colleagues as published in BMJ Open a couple of years ago. This becomes a particular problem when we're thinking about talking therapies. Now, the largest platform for the delivery of talking therapies is IACT, which is an acronym for Improving Access to Psychological Therapies. It was set up in 2008 by David Clark from Oxford and Lord Layard at London School of Economics. And it provides a single point of access, for those of you who are not aware, for the delivery of evidence-based treatment for depression and anxiety. It's transformed the treatment of anxiety and depression with considerable success. IACT sees over 1 million referrals a year. About half of people enter treatment, and treatment's divided into high and low intensity care. And a key performance indicator is recovering, which is moving from being a case of depression or anxiety to not being a case. And IACT can confidently state they've managed to get 52% of people recovery. But there's what about the remaining 48% of people who don't recover? And we know something about that population because work within the ARC and with colleagues and collaborators from Somerset has found that actually one of the variables that seems to impact on whether or not you get better from IACT treatment is whether there's concurrent personality difficulties, which lead to more complex emotional needs, which 6 sessions of CBT just won't fix. And we found in a paper published 2 months ago in the Journal of Affective Disorders that the presence of concurrent personality difficulties, and I'm talking about things like impulsivity, high levels of trait anxiety, these existing problems are going to be associated with less likelihood of recovery from depression and anxiety. So one of the things that we're wanting to take forward is a mixed method study examining the need for enhancing therapist skill base to manage patients with more complex emotional needs, so less patients fall between the gaps. I'm just going to rapidly move on to talking briefly about this group. This is a young person who's going to see her GP, and we know that primary care is not an easy space for young people to access, sometimes to talk about their concerns, their anxieties. And this is an area that we're interested in terms of thinking about the space of fragmented care. So a project that Lucy, my colleague who joined us on the Q&A, is leading with myself and others, funded by the research councils, is looking at the possibility of enhancing the value of online GP assessments by using digital technology. In other words, is it possible to use digital information from a young person's smartphone with their consent to enhance history taking and to enrich consultations? So Lucy's been leading, this is a complex project. I can't do it justice in 30 seconds, but there's been a range of stakeholder engagement with young people, their parents and GPs, a pilot study looking to see whether data sharing from a smartphone, looking at specifically data on mental health, is feasible and acceptable. And then the aim is to complete a Delphi study where we will develop some clinician guidance for discussing harmful online activities with young people. Okay, moving on to the area of the workforce. I said this was another area. So we're all very used to seeing Hugh Edwards presenting another dreadful day at the Royal London Hospital or at Western or any number of our hospitals across the world, across the country, looking at the devastating impact of the pandemic. And we know there's been a lot of talk about the front line, and ARC West and myself colleagues have been lucky enough to join a flagship study which is looking at the psychosocial impact of the pandemic on the UK healthcare workforce. So the study is led by Simon Westley at King's with funding from the MRC and a bit of funding from Wellcome. And I'll just tell you a little bit about that. I won't dwell too much on this slide because I think everyone is very familiar with this problem, but healthcare workers, the wartime analogies get tiresome sometimes, but it has felt sometimes like a battlefield out there. I work with the liaison team at the BRI, and it's very stressful for staff. People worrying about their much heightened risks of infection, providing care, with often staff getting redeployed to unfamiliar settings, and just the learning to be in a different environment, very stressful, worries about PPE and inadequate supply, and then worrying about picking up an infection and then taking that back home to your family. So all of this, it's not rocket science, it's going to make people stressed, and people have been getting stressed. Does it lead to an increase in depression and anxiety? That's a key question. And last April, as part of ARC activity, led by James and colleagues within the ARC, we undertook, at the request of Gloucester CCG, a rapid scoping exercise where we were looking at the impact of the pandemic on mental health outcomes, including the healthcare workforce. And at that particular point in time, there was a lot of fear and concern, but very little empirical evidence. What had been published was very selected samples, prone to bias. And so there needed to be more research. And into that space has arrived NHS CHECK. That's the name of the study. So I'll tell you a little bit about that and give you some headline findings from NHS CHECK, to which ARC West are contributing. The objectives of NHS CHECK are to describe the prevalence of distress, to then look at within the workforce, and we're looking by the workforce, I'm talking about clinical and non-clinical staff, so administrators, porters, everyone who works in a hospital, to then look at what work factors are associated with poorer and better mental health in the pandemic, then looking at how these patterns of distress pan out over time, to then evaluate qualitatively the staff support programs that have been put in place, and then to use this as a recruitment platform for undertaking RCTs of interventions to help staff. Apologies for the slightly busy slide. I won't go into all the methods, but suffice to say is that the data is all collected online. We're collecting data from across 18 trusts across England. From all staff are invited to take part. There's a short 10-minute survey where everyone fills out demographic details and then a question about whether they're suffering from depression or anxiety. Then there are longer optional questions, which actually most people are completing, on post-traumatic stress disorder, moral injury, depression, and alcohol use. In terms of next steps, there's a lot going on with this project. We're following people up at 6 and 12 months. We just started the follow-up data. There's plans for a randomized controlled trial where we're randomizing people to a well-being app or immediately or a waitlist control to see if that can help improve the amount of support. There's also a qualitative study, which is planned to look at the value of staff support interventions and looking at why some people aren't using these support interventions. And then a more detailed diagnostic interview study, because of course all that data is self-report on symptoms, and that sometimes can overestimate and inflate prevalence rates. I'm just going to move before ending to a couple of other areas. I said I'd say something about suicide. We're doing, in a different space, work on, and it does relate to fragmented care as well. Some of the people who are at higher risk of suicide, forgetting the pandemic, are people who've got concurrent substance misuse problems. And we see people regularly arriving at the emergency departments in a suicidal crisis who have coexisting substance use problems, but it's unclear which service is going to look after them. And so with support from funding from the Above and Beyond charity and colleagues in the ARC, we're undertaking a pilot study, which is we're trying out a new telephone-based suicide prevention intervention for ED attenders with substance misuse. And we're commencing that testing from April next month. The final thing I want to say, back to the theme of COVID, which we seem to, we can't escape from. There have been a number of reports across the world we're hearing about, in a very distressing way, the deaths by suicide, from suicide of doctors and nurses and paramedics. And we know that these occupational groups are, before the pandemic, were at risk of, elevated risk of suicide. But there are fears about whether the pandemic is escalating those risks. And so another piece of work we're doing in the ARC, and this is work that's led with Swansea University, colleague Anne John here underlined, and under Julian's guidance from the evidence-based theme in the ARC, is we're looking at the newly emergent literature and the best literature on self-harm and suicide prevention in the context of the pandemic, including within this a sub-study which is looking at the trends globally in the published literature on suicide amongst healthcare workers. So this is work that I'm currently leading with Emily. There's so much more to say, but I'll stop. I think I'm well over time. Thanks for listening.